Welcome to AETCM, the emergency medicine channel. Today let us discuss about polymyositis. Polymyositis means multiple muscles are involved. Their inflammation occurs. The inflammation of muscle cells that is seen in almost all muscles in the body. That is polymyositis. And dermatomyositis. Dermatomyositis means along with myositis, polymyositis, patient develops some skin manifestation, that is dermatomyositis. We will see what is this polymyositis and dermatomyositis. Polymyositis, we know that it's an inflammatory myopathy. We can see many types of myopathy like infectious myopathy, inflammatory myopathy, like some infections can produce myopathy or immune mediated myopathy can occur. This polymyositis is generally an inflammatory immune mediated myopathy. It presents with severe muscle weakness and tenderness, that is classical. Chronic myopathies are commonly present without any tenderness in the muscle, but here the patient has severe muscle tenderness and weakness. It occurs mainly proximal group of muscles. The myopathy is symmetrical, bilaterally you can see the same group of muscles are involved, and their proximal muscles are predominantly involved, proximal more than distal. Distal muscle involvement is very rare in polymyositis, but rarely some type of myositis like inclusion body myositis can have distal weakness also. Normally proximal weakness is more than distal weakness. This mainly affects the skeletal muscles, but sometimes you can see cardiac muscles also can be involved, like patient can have cardiac involvement also. And it is mainly symmetrical and proximal muscle weakness. It is associated with severe muscle tenderness and elevation in the muscle enzyme, that is creatine kinase. The main muscles affected are deltoid, hip flexors, abductors, extensors, and neck flexors also involved. So mainly upper limb and lower limb proximal muscles and neck flexors are mainly involved. Neck extensors are not commonly involved. So we have already discussed that it is symmetrical proximal muscle weakness. Muscle enzymes are elevated, like creatine kinase is highly elevated, and EMG is an investigation which can tell you that where is the problem, whether it is in the muscle or what type of muscle involvement is there. All these things can be picked up by electromyography, that is EMG. And muscle biopsy is very important. Sometimes muscle biopsy can give what type of pathology is going on in the muscle. That is also very important. That shows endomysial, mononuclear inflammatory infiltrate and muscle necrosis in polymyositis. So it is an autoimmune disease and it can be associated with sometimes other autoimmune diseases like SLE, scleroderma, and it can also associated with malignancies, and it can be produced by some viral infection, bacterial infection. So these viral infection and bacterial infections are actually a trigger for this immune mediated muscle injury. So this is a dysregulated immune mediated muscle injury. But sometimes the normal viral fever or leptospirosis, they themselves can produce muscle injury, polymyositis. That does not come under polymyositis of this category. They are infectious polymyositis or tropical polymyositis. That is a different entity, can be seen very commonly seen in leptospirosis in our country. It's a T cell mediated cytotoxic process directed against unidentified muscle antigens. So this is a T cell mediated immune mediated injury that can be triggered by various diseases like SLE, scleroderma, malignancies, viral infections, all these things. Now there are some antibodies identified in polymyositis. They are myositis specific antibodies. They are aminosyl transfer ribonucleic acid tRNA synthetase anti-Jo1 antibodies. That is this classically known as anti-Jo1 antibodies. Nuclear Mi2 protein components of signal recognition particle SRP. These are the common antibodies we can see in this type of diseases. Anti-Jo1 antibody is commonly done in routine lab as a routine lab investigation in polymyositis. Another type of antibodies, myositis-associated antibodies. They are found in 20 to 50% of the patients, are commonly associated with other connective tissue disorders like polymyositis, scleroderma, nuclear antigen, nuclear cave antigen, small nuclear ribonucleoside proteins, cytoplasmic RNP. So these are the other types of antibodies. Now, when we know that it is a dysregulated immune mediated mechanism, we know that some viruses can trigger this problem, some malignancies can trigger this problem, and some autoimmune diseases also can trigger this problem. In that, common viral triggers are Coxsackie-B1 virus, HIV virus, HTLV1 virus, hepatitis B virus, influenza virus, echovirus, adenovirus. These are the common viruses which can involve in this type of problems. You can see the patients who is having leptospirosis or other common viral infections also can produce some amount of myositis, but you can see that in that type of myositis, elevation of CK is only marginal, up to 1000 or 5000, 6000 like that. Whereas in this type of myositis, inflammatory myositis, the creatine kinase elevation is very, very high, around 40,000, 50,000, 60,000. That is the range of elevation of creatine kinase. That is a muscle enzyme. Whenever there is a muscle injury, creatine kinase will increase. It is not CKMB, it is creatine kinase, CK. Now, some drugs also can produce polymyositis, but they are not severe, especially statins. So, simvastatin, rosuvastatin, atorvastatin, all these statins which can produce some myositis. These drugs are mainly used in cholesterol control. So, whenever we start these drugs, normally we have to do CK after 2-3 weeks, or if the patient complaining about muscle pain, we have to stop these drugs. We have to go for alternative drugs instead of statins. Dipenicillamine, hydralazine, procainamide, phenytoin, AC inhibitors all can produce inflammatory myopathy, but not very commonly seen this type of myopathy. But this type of myopathies are very commonly seen in statin therapy. Now, dermatomyositis means polymyositis with a component of skin rash, skin lesion. Like there are a lot of skin lesions we will see afterwards. Gottron, papule, heliotropic rash, Shawl sign or wheel sign, Erythroderma, mechanics hand, psoriasis, thick changes in the scalp, Holt's-Tail sign. So many signs or skin lesions can be seen in dermatomyositis. So we have discussed that polymyositis generally involves all the muscles in our body. It is symmetrical. Proximal muscles are predominantly involved, and muscle pain is classically seen in most of the patients with muscle tenderness. That is very classical. Muscle tenderness in the proximal muscles are very classical. Dysphagia is seen in 30% of the patients. Arthralgias are very common, and weak neck muscles, that is also very, very important. Involvement of pelvic girdle, so that patient is unable to get up from squatting position. Cardiac involvement can be seen in some patients. Cardiomyopathies, pericarditis can also be seen, but not a routine involvement. Skin rashes over the face, neck, back, everywhere you can see the skin rashes. Similar type of skin rashes can be there. That is seen in dermatomyositis. Now, another type of immune-mediated myopathy is necrotizing autoimmune myopathy, or NAM, inclusion body myositis. In that, inclusion body myositis is very, very important, because inclusion body myopathy is one myopathy that is classically involves the distal group of muscles. This type of myopathy, like necrotizing autoimmune myopathy, is commonly associated with malignancies. Inclusion body myositis, we have already seen, that is a progressive idiopathic inflammatory myopathy, and it is classically involves the distal group of muscle. It is very common in elderly individual. Now these are some of the changes you can see in dermatomyositis. One is Gottron's papule, scaly erythematous papules over the extensor surfaces of the proximal and distal interphalangeal joints. So this is very classically seen in white skinned people, but in a normal Indian patient, it will be difficult to identify this type of changes. But this can be seen in many patients who is having dermatomyositis. Another important type of rash is heliotropic rash. Heliotrope rash is seen over the eyes. It is a violent discoloration of the eyelid with periorbital edema. Similar rashes are seen in other parts of the body also. Another sign is V sign or shawl sign. You can see V-shaped rashes on the neck and upper part of the trunk. Erythroderma is throughout the skin. You can get red skin. So that is erythroderma, redness of the skin. Mechanics hands, in some patients you can see roughening and cracking of the skin of the fingers. There are a lot of other changes, psoriatic changes in the scalp, calcinosis cutis, there is calcium deposits in the skin. Other associated features with dermatomyositis, interstitial lung disease can be there in patients who is having SLE or scleroderma, who is having polymyositis or dermatomyositis. Malignancies are associated with dermatomyositis. Esophageal dysfunction can be seen in many patients. Patient can also have fever, weight loss, Raynaud's phenomenon, polyarthritis, SLE, scleroderma, overlap syndromes. All these things can be associated with polymyositis, dermatomyositis. So these patients can also have the features of diseases like scleroderma, SLE or other malignancies. Now, if you see the classification of polymyositis, primary idiopathic polymyositis, that means there is no association with other autoimmune diseases or malignancies. Primary idiopathic dermatomyositis, polymyositis dermatomyositis associated with some malignancy. Polymyositis dermatomyositis associated with vasculitic disorders. Polymyositis dermatomyositis associated with collagen vascular diseases like SLE, scleroderma, all these things. So there are 5 categories. In that, primary is one, and secondary you can see in malignancies, vasculitis and collagen vascular disease. Basically they are divided into only 2, primary and secondary. Primary is without any reason. Secondary you can see in malignancies, vasculitis and collagen vascular disease. Then cancer associated dermatomyositis. Cancer occurs in 25% of the dermatomyositis. They can have severe rashes and severe muscle weakness. They can be associated with prostatic cancers, breast cancers, ovarian cancers, lung cancers, GI malignancies, non-Hodgkin's lymphoma, pancreatic cancers, bladder cancers. So all these cancers can develop polymyositis or dermatomyositis. So the important thing is, when we get a polymyositis or dermatomyositis, if we are not able to find out major causes, we have to investigate this patient for any malignancy, including PET scan we can do, because sometimes occult malignancies can present with polymyositis or dermatomyositis. In that case, we will have to investigate for an occult malignancy. That PET scan is one of the important investigation in finding out the occult malignancies in our body. Now, one of the most important investigation in polymyositis is creatinine kinase. We know that creatine kinase is produced from muscles. When the muscle injury occurs, creatine kinase elevates. If we take 1 or 2 IM injection, we can see creatine kinase elevates in 100 range. If you have a viral fever like COVID or any other viral fever, again it may be the CK may be 100, 200, 300 in that range. If you see leptospirosis, it may elevate in thousands, like 1,000, 2,000, 3,000, up to 10,000 you can see in many patients. But in polymyositis you can see 50,000, 60,000, 70,000, that is the range. So very high levels of CK is classically seen in polymyositis. Then once you make a diagnosis with the history of generalized weakness, muscle tenderness, muscle pain, proximal muscle weakness, we will do CK. CK can be classically elevated. Sometimes serum creatinine also can be elevated because this rhabdomyolysis can produce renal failure. Once you make a clinical diagnosis of polymyositis, we can do muscle biopsy. It can be done from quadriceps or deltoids. So that is very important. We can do muscle biopsy also. In dermatomyositis, we will have to do skin biopsy. Now, antibody test we have seen previously. ANA can be positive in up to 80%, but ANA positivity alone will not tell you that this is polymyositis or dermatomyositis. ANA can be positive in 80%, but strong clinical suspicion should be there before doing all these antibody tests. Anti-Jo1 antibody is very, very important antibody. It's a myositis specific antibody. So if this is positive, this anti-Jo1 is positive, the response to clinical treatment is very bad. So they may not improve the clinical treatment. Other antibodies which can be done, which can be seen in other connective tissue disorders or overlap syndrome, like anti-Rho antibody, anti-LA antibody, anti-SM antibody, anti-ribonucleoprotein antibody, RNP1 protein. So these are the other investigations we will have to do. And we may do malignancy workup in many patients. We can do chest X-ray, ultrasound abdomen, look for any tumors in the abdomen, chest, any mediastinal masses, pap smear. So many investigations can be done to rule out malignancy, especially in elderly individuals. Thyroid scan, bone scan, etc. Now, electromyography should be done in all patients who is having polymyositis. Cardiac workup like ECG can be done. Simple ECG can pick up pericarditis. Myocarditis can present with conduction abnormalities or tachycardia, unusual tachycardia. ILD can be ruled out by pulmonary workup because ILD is a very classical presentation of, or very common presentation of scleroderma. So that should be done. Electromyography can be done in all patients who is having polymyositis. That shows evidence for membrane irritability, increased insertional activity, fibrillation potentials, positive sharp wave at rest. So these are the common findings in electromyographic changes. So that can be done for all patients. Now once you make a proper diagnosis of polymyositis clinically, we can do CK. CK will be very, very high. Then if possible, we can do electromyography or muscle biopsy. All these things will take time because muscle biopsy may take at least 2 to 3 days. Before that, we have to start treating. We have to start the treatment for this patient because severe muscle injury can lead to so many other complications like renal failure, permanent damage to muscles. All these things can occur. So immediate treatment is important. Complete bed rest is mandatory. So you have to advise complete bed rest for the patient. Physiotherapy should be started only if the patient's pain is subsided. That is very, very important. The next important treatment is methylprednisolone, that is steroids. The advantage of steroids are immediately it acts. Okay. If you use other drugs, the immediate action is not seen. So steroids can be used as a bridge therapy to other types of treatment. So pulse dose is usually given in severe polymyositis. Pulse dose is given. Pulse methylprednisolone 1000 mg per day for 3 days. Then we can switch to oral prednisolone 1 mg per kg body weight can be started and can be continued up to 4 to 6 weeks. Then slowly taper the dose over a period of 6 months or 3 months. Another drug is important drug can be given initial phase itself, that is anti-CD20 monoclonal antibody, that is rituximab, that can be tried. Once the patient is stabilized on steroids, steroids cannot be continued for a longer time because steroids itself can produce myositis. So as soon as possible we have to taper and stop steroids, and we have to start steroid sparing agents like methotrexate, that is one of the important drug which can be given for polymyositis. 15 to 25 milligram per week can be given. Along with folic acid we have to continue, because if we are not giving folic acid it can produce severe granulocytosis. So methotrexate with folic acid, that is very important. Azathioprine can be given, that is also steroid sparing agent, 50 milligram per day can be continued. HCQS, hydroxychloroquine, is an alternative for many muscle diseases, polymyositis. Tacrolimus is an alternative. Cyclophosphamide is an alternative for pulse therapy, pulse methylprednisolone therapy. It has got its own adverse effects, so it should be given with adequate hydration, antiemetic, mesna, all these things should be given, otherwise hemorrhagic cystitis also can occur. Next important alternative in emergency room is IV immunoglobulin. IV immunoglobulin dose is 1 to 2 gram per kg ideal body weight over 2 consecutive days. IVIG can neutralize the antibodies in our body, so that can be tried. Rituximab we already discussed, so in acute condition we can give pulse methylprednisolone, cyclophosphamide, IVIG or rituximab. Rituximab dose is 1000 milligram can be given start, again after 2 weeks we can continue the treatment. MMF is an oral drug, mycophenolate mofetil, that can be given as 1000 milligram twice daily. It's a very very good drug, lesser side effect when we compare with other steroid sparing agents that can be given. Cyclosporin is also an alternative. So we have discussed about one of the important differential diagnosis for acute flaccid paralysis. When we discuss about acute flaccid paralysis, we know that it is very common in emergency room. Patient can come with ascending weakness like GBS, all muscle weakness like hypokalemia, hypophosphatemia, snake bite. All these things are differential diagnosis. Myasthenia gravis, tick paralysis, botulism. So many differential diagnoses are there for acute flaccid weakness. Polymyositis is one condition which can also present with acute flaccid weakness, where all muscles are involved, predominantly proximal muscles are involved. All the deep tendon reflexes are sluggish or completely absent. There is no sensory loss because spinal cord is not involved. CK will be very high in this type of patient, around 40,000, 50,000, 60,000. That is the range of creatinine kinase in this type of patients. If the patient go to rhabdomyolysis, creatinine also can be elevated. These type of patients require steroids. Steroids are the acute emergency treatment for polymyositis. Alternative drugs we already seen, IVIG, rituximab, cyclophosphamide. There are a lot of alternatives. Same like other autoimmune diseases, they should be continuously treated with mycophenolate mofetil, methotrexate, azathioprine, all these things. All patients who is having polymyositis and dermatomyositis should be evaluated for other autoimmune diseases like SLE, scleroderma, other types of vasculitis and malignancies. Thank you.